Welcome to the next webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled Integrating Psychopharmacology in Primary Care, When and How. Before we get started, please note this webinar is for informational purposes only. Please consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practicesustainability@ama-assn.org. This series is a collective product of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care during the COVID-19 pandemic and beyond. This webinar will cover the ins and outs of integrating psychopharmacological treatment into a primary care practice. Experts will explore available tools and resources to assist physicians in determining the need for a psychopharmacological intervention, along with key steps and interventions physicians can take to address routine and complex behavioral health conditions. Joining us today are Dr. Ryan Lashover, Program Director for Waco Family Medicine Residency and Editor-in-Chief of the Waco Guide to Psychopharmacology and Primary Care, and Dr. John Kern, Clinical Professor of Psychiatry and Behavioral Science at the University of Washington Ames Center. And with that, I will turn the conversation over to you, Dr. Kern.
Thank you, Chris. Glad to be here. I'll jump right in. I'm going to be speaking about what I think about the advantages and the joys and sorrows of doing psychiatric consultation in primary care. In brief, I think that in some ways, primary care is the best place to do psychiatry. Why do I think that? Or where do I get off saying that? I have 27 years in the primary psychiatric world as a community mental health center psychiatrist. I've been a psychiatric consultant in primary care for 15 years, 2 years as a straight up primary care medical director. I've taught thousands of providers about collaborative care of mental health conditions in primary care. I work with primary care clinics every week, and I gave my firstborn child to primary care, who is a family medicine resident. One of the things about primary care is it has a responsiveness and an ability to respond to medical issues in particular and to emergencies. It's just not available in the psychiatric setting in the vast majority of examples. So things like getting labs, available appointments when you need one, the fact that primary care is used to dealing with chronic disease. These things are all really important and really welcome if you're treating psychiatric disorder. Next slide, please. Next slide, please. In the best primary care psychiatry, you do simple things well. You prescribe standard meds, you assess on time, and you make changes on time. The things that make the difference between effective and ineffective care are dead simple, but not necessarily easy to execute. So here's an analogy. How easy is it to get enough sleep, eat healthy food, exercise regularly, and remember to floss? It's easier to talk about, hard to execute. Very similar. Next slide, please. Psychopharmacology is not, psychopharmacologic treatment is not the only choice, but it is maybe not even the best choice in some settings, but is frequently appropriate. If people want something else or are not ready for that, you probably need to follow them. There are a lot of people who feel that psychopharm is the way to go for them. It's the treatment that feels like treatment to them. Other people, not so much. They need to come around to it. This does not mean do whatever they prefer. For example, the use of benzodiazepines inappropriately, the use of sleepers willy-nilly, and such things as an ADHD diagnosis on the fly. The brief behavioral interventions that we recommend, like sleep hygiene, deep breathing, relaxation, problem-solving therapy, these are simple. These things can work. Next slide, please. in terms of assessment, the use of rating scales and a team-based approach make primary care mental health possible. Otherwise, it just takes too much time. The other thing about make assessment is a relatively brief assessment leads to what I think of as presumptive treatment. If someone came in, for example, without a lot of other diseases and had persistently elevated blood pressure, you probably treat with antihypertensive. And if it didn't work, then you'd start thinking about a complicated workup. Then you start thinking about the condition of the renal arteries. Otherwise, if you start with basic treatment for basic conditions. In psychiatry, it's the same. It's often quite a while before you and the patient learn what the problem is. And often you don't learn this before you start with basic treatments. Next slide, please. So basic treatments work. Even for complex individuals, there's a notion that a lot of people I work with have that psychiatric patients are too complicated to effectively treat in primary care. And often basic interventions, basic interpersonal interventions, basic psychopharmacological interventions are really effective for people even who come in with checkered, complicated pasts. Treatment in the primary care setting depends on things like medication changes on time, adequate dosing, and 90% of my consultative advice is optimize the dose of whatever it is they're taking. And this is something that's often not happening on time, and this is one of the things that makes the difference in a consultative model. I would point out that measurement-based care is a key to success, the use of rating scales and following them, getting the measurements and responding to them for things like the PHQ-9 depression rating scale. Measurement-based care is powerful, and not just in the collaborative care setting. There's a really interesting article by John Rush from 2015 called "Isn't It About Time to Employ Measurement-Based Care in Practice?" And even in specialty psychopharm settings, what they found is that it makes a big difference if you use measurement-based care. Next slide, please. Complications. Complex disorders, for example, bipolar disorder, are hard to treat alone. Now, I don't mean that they're not appropriate for treatment in the primary care setting. There has recently been, in the last year, a large study published by the University of Washington called the SPIRIT trial, in which 1,004 patients with bipolar disorder and/or PTSD were treated in FQHCs, half of it which were done with collaborative care, and it worked. It was a powerful intervention. My point is that you probably want to have help with doing that if you're a primary care doc. Ideally, it involves a team, like described here, primary care, psychiatry, other behavioral health colleagues. So if you do the simple things without success, what do you do then? If you get really far down the algorithm for treating a patient, you definitely need help. And one of the things I like to suggest to people is to even consider paying someone a psychiatric consultation for the occasional half-hour phone call if you have no other formal kind of arrangement. And we'll talk more about that later. And with that, I will stop with my consultative perspective and hand off to Dr. Lashover, who's going to talk about the truly awesome Waco product.
Well, hello, everyone. Again, my name is Ryan Lashover. Can you please play into the next slide there? I'm a family medicine physician, program director here at Waco Family Medicine Residency, as well as the editor-in-chief to Waco Guide to Psychopharmacology and Primary Care. And as you advance to the next slide, I'll share a little bit about our story here at Waco Family Medicine. And it started with both the challenge and opportunity that you guys feel every day, that most patients who have a behavioral health disorder enter through primary care. But unfortunately, primary care is under-supported in this role to care for these patients as well as we like. 2/3 of primary care docs, if they wanted to refer their patient to a specialty care, don't have the option to. And we see this care gap worsen in a lot of communities that you all may be practicing in, whether it's in the rural or underserved communities. And so in the next slide, please. We integrated behavioral health in our system about a decade ago with licensed clinical social workers that really assessed the care and improving detection rates of mental health disorders. And we saw those detection rates really start increasing in our system. But when detection rates increase, the treatment burden also increases to the behavioral health team, to the primary care team. And so we saw an increased need to help treat these disorders further and better. And so next slide, please. And this is challenging. Primary care clinicians may feel less comfortable with behavioral health treatment. There's significant data that articulates that. Unfortunately, most guidelines for behavioral health disorders are not written with primary care clinicians in mind. And the proficiency of prescribing for many primary care clinicians may be lower for prescribing psychopharmaceuticals. And so next slide, please. We were sitting asking ourselves there, how can we provide high quality care for behavioral health disorders in the primary care context? And so next slide, we turn to clinical decision support tools here. Clinical decision support tools, their goal is to weave guidelines into action. Their goal is to make guidelines become accessible at the point of care when we're in the exam room or talking with our patients. So we created something called the Waco Guide to Psychopharmacology in Primary Care. Next slide, please. These decision support tools have three primary components to them. They have an algorithmic structure that's used to guide decision-making for the treatment, the psychopharmacology treatment of behavioral health disorders. They have key prescribing information, highlighting dosing, titration, schedules, and monitoring parameters. This is not the physician's desk reference of every side effect that is done, but key side effects that you typically want to recall in the exam room. And also a strength of recommendation taxonomy, sort ratings there that really highlight the strength of recommendation as it is articulated by literature and expert opinion in the decision support tools. Next slide, please. It's vital that these tools are reliable, that they're succinct, and that they respect cost for patients. There's many options out there that aren't affordable for many of our patients, and that it expands the scope of primary care. That this is both adult, pediatric, perinatal psychopharmacology, and that these are ethical, not industry funded. Next slide, please. We looked at the Project Echo model to really, the Project Echo model involves a team of specialists that then relays that information to primary care clinicians, then further to the patients that they're able to take care of. And so this Project Echo model really shares this specialty specific information along with guidelines to a larger group there as well. And next slide, please. That specialty consultation for us resulted in a neat consultative relationship with Massachusetts General Psychiatry Academy, where we really lended the primary care expertise, and Massachusetts General Hospital Psychiatry Academy listed the psychiatry expertise. And next slide. That resulted in the creation of something called the Waco Guide to Psychopharmacology in Primary Care. It's a collection of more than 60 primary care focused psychopharmacology decision support tools, encompasses the treatment of routine and complex behavioral health disorders. And really, it not only is what the disorder by itself, but in primary care, we know that our patients come in with multiple comorbidities. And so it addresses the treatment of these issues in line with their comorbidities as well. So it's an individual with depression and hepatic failure, or somebody who maybe have bipolar and is pregnant at the time. And so it addresses the wide range of comorbidities as well. Next slide, please. So I just shared before, you can see the Waco Guide to Psychopharmacology in Primary Care at the website, wacoguide.org, wacoguide.com, as well as the Waco Guide app here. And I think in some of our future discussion, we'll be able to highlight some different areas where we can use tools like this and some others to really enhance primary care treatment of behavioral health disorders.
Thank you, Dr. Kernan and Dr. Lashover. Really looking forward to kind of getting under the hood a little bit on this important topic area. So to kind of start our conversation off, let's start with a conversation just broadly for the both of you all. What are the main things that primary care physicians need to be successful in psychopharmacological prescribing and treatment? And maybe starting with you, Dr. Kern, and then we can turn it over to you, Dr. Lashover, for your thoughts.
Great, thanks, Chris. So I'm going to toss Ryan a softball here. When I sat down to answer this question, kind of cold, not thinking, thinking about this presentation per se, the two things I wrote were rapid access to useful information at the point of need, and reminders to do things on time, and mechanisms to not let cases slip through the cracks. And of course, what Ryan is going to tell us is this is precisely what, particularly the rapid access to useful information, is precisely what the Waco Guide does. But I think those things are really, if it's not low barrier for the provider, it doesn't happen. What do you think, Ryan?
Yeah, absolutely. And I think for primary care clinicians, I think appropriate assessment is important. We have to have a good idea of what we're looking at. And I think Dr. Kern, you shared an introduction, and sometimes that is clear and sometimes that's less clear. primary care offers itself a unique opportunity because we build those relationships with patients so much that hopefully over time that diagnosis becomes more and more clear. I think integrating tools, the vast amount of information that we are responsible for in primary care widens every day. Everybody listening to this call knows that. And so integrating tools that can help facilitate your practice, that actually expedite the care and help you provide more and more guideline concordant care is vital to practice every day. I think you got to know your community. And so for some communities, you may have great behavioral health support. For some communities, you may not have great behavioral health support, but potentially statewide. Here in Texas, it is difficult for me to provide a psychiatry consultation, but we have a new psychiatry access children's network that I can call and within 30 minutes have a phone conversation and consultation with an individual. And some of those can be huge keys for your community and for your state.
Yeah, by the way, there are similar University of Washington phone access lines that are these fabulous resources. They're underused. And so if I could take this opportunity just to wave the flag for these kinds of things, which exist in lots of states. It's free, sudden access to a really smart person. So don't forget that that's there.
Absolutely. Yeah, we've highlighted a few. I know Massachusetts and a few other areas as well that have them that are in some of our resources and some other webinars, and definitely fully support the utilization and support of expansion of those types of access programs as well. So for you, Dr. Lashover, who should conduct the initial assessment and create a plan for the specific patients that you're seeing?
Yeah, I think for the initial assessment, there's the screening and there's the diagnosis to it. And so the screening side of things, this is where the behavioral health team really comes in. And that your behavioral health team is your nurse. It is a behavioral health worker if that's a part of your team right now, and it's you as well. And so there's multiple individuals along the way that may be conducting a PHQ-2 screening measure. But also in primary care, there's other measures that we use to screen. When we think about a patient with 2 or more uncontrolled chronic conditions, they have an 8 times increase of having underlying major depressive disorder. There's screens that we do, is what I'm applying here. There's screens we do every day, in addition to the validated psychometric principles that we do as well. And then I think when the diagnosis comes into play, the primary care clinician or the clinician has to be key to that. There's parts of the DSM criteria that involve ruling out other disorders, other medical disorders that were key to kind of solidifying that diagnosis.
Anything to add to that, Dr. Kern?
Yeah, I think that I would agree with pretty much everything that Ryan said. I think that there are a lot of ways to skin this particular cat and to get, initial screening is very powerful. Having a plan and executing it, like with a lot of these things, is the trick. If you screen everybody, or at least who you decided to screen. So I think there's a lot of ways to do it. But the smart practice doesn't want to let that go to the back burner.
Great. So staying with you, Dr. Kern, what are some key prescriptive principles when initiating psychotropic pharmacotherapy? And how should primary care physicians go about choosing what to prescribe?
Well, it's kind of hard to argue with Ryan's guide. What I wrote is you want to choose tested treatments at the right dose. And so you want to there's no particular reason to go too far afield. In my practice, I tend to recommend that people use the basic psychopharm agents because they work, and because we get to know them, and the more the providers use them, the more familiar they are with their ins and outs, and using them at the right dose. So that both means starting at the right dose. Sometimes that means starting low and going slow, but proceeding through the titration to in a timely fashion, as quickly as makes sense, to the maximum dose before you say, I've got a finished trial and move on to the next thing. But in some ways, I don't want to quite say it doesn't matter what you start with. Of course it matters. but it's not in some ways complex. You start with basic treatments before you do simple things before you do complicated things. It's just, you just want to execute the simple things properly.
What about from your experiences, Dr. Lashover?
Yeah, absolutely. I think in those realms, there's often a lot of right answers of what medicine to start with first, and get comfortable and confident in a few options that work well for you in your practice. Just like ACE inhibitors when treating hypertension, there's quite a few examples. Those on the call probably pull to one, maybe two pretty darn routinely. And there's reasons why. And so we suggest the same side of logic for a lot of behavioral health disorders. I think being comfortable with the first 1 to 2 treatment steps of the vast majority of behavioral health disorders. And then I agree with Dr. Kern so much. Start low, go slow. But then our mantra after that is you got to go. You got to titrate these doses.
I like that.
Yeah, the number one kind of error that we see in psychopharmacology and primary care is inadequate dose titration. And so for most disorders, yeah, you're titrating these medicines for most areas, and every medicine's unique, but every 1 to 2 weeks until 1 of 3 things happen. You get an adequate response, you have intolerable side effects, or you reach the maximum recommended dose and there's no response. But really, you should keep encouraging titration of that dose until you hit 1 of those 3.
Mm-hmm.
And that's the number one error that we see in primary care.
I completely agree. Like I was saying, I get paid to say this many times a week.
Amazing. So, Dr. Kern, what is considered an adequate trial based on kind of the discussion we're just having before declaring an inadequate response to a psychotropic medication? And what should primary care physicians do after a failed trial?
Well, so we just got done saying, what you want to do is make sure that you've used an adequate range of doses for any medication that you started. The worst possible thing, that you can do is, start with a small dose of one drug and then abandon it and go to small dose, another one, and then a third. And after a while, a year and a half has gone by and you don't know anything about what works and what doesn't work. And this happens all the time. I think my rough rule of thumb is that we would like to see at least 6 weeks at a full dose. I think that that's on the brief side, but I often say, actually when I'm titrating, I'll often say 4 to 6 weeks, even though I know that's a bit on the short side, because I'm hoping for 6 to 8. It's kind of like, you have the guest is always late, you tell them the party's at 5 when it's at 6. And I'm partly joking and I'm partly not joking. That's how it actually works out. But the point being, you want to be timely about moving forward. If you get there, if you're 6 to 8 weeks at the highest dose, then you move on to the next trial. And I think the thing the hitch that people run into right there is the notion that it feels like you're barking up the wrong tree. You get somebody in, they're suffering, they're depressed. You give them the treatment. It takes a while to go to titrate through a bunch of doses, especially if you go slow. And so you're looking at months, and then your treatment is a failure. And that's gonna happen most of the time. Go look at the statistics, 70% of the time, probably your first trial is gonna be a failure. And so everybody thinks this is never gonna work. This is a bad idea. This psychopharm thing is no good. Maybe the diagnosis is wrong. And that's just natural. I even feel that. And you have to remind yourself of the evidence and move forward with another trial. It takes 2, 3, 4 trials to get most of your folks better. And so you have to remember that, because your gut is going to tell you different.
Yeah, and I absolutely agree with Dr. Kerner. I think it's so important to normalize that there's far from 100% success rate on first or second pharmacotherapy trials. Patients need to hear that. They need to hear that despite an inadequate trial, that there is that the likelihood of success is still high, and that you're there for them to help them walk through this pathway there. I think that's an opportunity to reconfirm, reevaluate your diagnosis there. And then I think this is really where most individuals on the call, for the vast majority of behavioral health disorders, have a good idea of their first line treatment options. But then second or third line treatment options can get quite a bit more complicated. And so having a good resource that's your go-to source I think is vital in those areas. That's where I think using a tool like the Waco Guide to Psychopharmacology and Care that will really guide those next level resources with respect to guidelines, literature, expert opinion, and real world primary care experience will really help guide some of those next treatment decisions.
Fantastic. And we've heard you talk a little bit, Dr. Kern, about the importance of that kind of consultative relationship between primary care physicians and psychiatrists. So how do primary care physicians go about facilitating that relationship when there may not be a psychiatrist in-house or they may not just have a current standing relationship with one?
Yeah, that's by any means possible is my short answer. The long answer is, if you know somebody. Yeah, I have many friends in the primary care business, and I don't work with them. They call me up. Somebody from school, you call them up and you say, can I take you to lunch? Can I buy you dinner? Can I offer you consultative help when you run into somebody with a neuro problem or a urology or whatever? You cultivate a relationship just like any other friendship that you cultivate. If you sit in your house and wait for people to call, no one will ever call you. Unless you reach out, you make efforts, some of which may not be successful, to find a guy or a person who can help you with this. I think that can be time well spent.
Any additional thoughts, Dr. Lashover, from your all's experiences? I know that in your area, it's been a journey for you all to try to work through that dynamic. Absolutely.
But I think, like anything, a meal or a cup of coffee just goes a long way. So I think my best consultative relationships happen in the doctor's lounge at our local hospitals and meeting for lunch and enjoying a lunch together. I think those efforts just go leaps and bounds to facilitate consultative relationships.
Great.
People want to help.
Yeah.
Absolutely.
And I would say for any psychiatrists who are listening, if you are engaged in that way, it's not a great burden. One of the things I do when I go into a primary care setting is say, call me. Here's my number. Here's my email. Get a hold of me. It doesn't happen very much. It's not a burden.
Absolutely. Dr. Lashover, I know you've talked a little bit about the Waco Guide. So, love to hear a little bit more perhaps about that and other open source tools that you're aware of that can help assist primary care physicians with psychotropic medications. So things like treatment length, dosage, titration, augmentation, etc.
Yeah. Part of the reason why we created the Waco Guide is because we were looking for things like it. We saw a need and said, gosh, behavioral health and primary care really needs support in this area. How do primary care clinicians get guided well? And so it's really created out of a need there. It is hard to capture the wider range or wide array of different recommendations. Adequate treatment lengths from an SSRI versus an atypical antipsychotic are vastly different, right? Versus a stimulant in some areas. And so I think finding a tool like the Waco Guide can be immensely helpful really to use at the point of care of your practice. And so using things, I highlighted disorder specific, but it'll highlight other areas too, like when you're transitioning from one SSRI to an SNRI or another SSRI, really providing guidance on how to move back and forth from some of those different areas is really key to your practice. So finding the tool that you know how to use well and incorporate in your practice really saves you time. And one of the neat things that we've identified with patients is actually very comforting to patients, often to have a shared language together, a roadmap to their success. And also, if you are able to form a consultative relationship with a local psychiatrist or somebody else, it's often a shared language between you all together and saying, I've treated past this first step. What's the next step together? And so it can be really a nice common language in those areas too.
Absolutely. Dr. Kern, any other kind of resources or tools that you're aware of that would be good for PCPs to at least consider or kind of look into
as far as I know, there's nothing like the Waco Guide. It's really phenomenal. So I wave the flag for the Waco Guide.
Fantastic. Well, we really appreciate both of you taking some time today. Any closing thoughts that you'd like to leave with our audience members? What can physicians do today? What can they do in the near term to really make a difference in this specific area? We'll start with you, Dr. Kern, and then Dr. Lashover, you'll have the last word.
Yeah, I say do simple things well.
And I just share an encouragement. I know this sounds intimidating to some individuals, but you can do this. Your patients want you to, they need you to, and there's tools that can help in this practice. And so just to encourage you all to engage in the treatment of behavioral health disorders.
Fantastic. Well, this was just such a really great conversation and some really helpful practical insights for our audience members. So just thank you both again for sharing your expertise and experiences with our viewers.
Thanks, y'all.
Thank you.
Be sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on our YouTube playlist. Please also check out the Collaborative's BHI Compendium for helpful framework on how you can make BHI effective in your practice, along with other actionable resources and practice case studies, which includes both on Waco Family Medicine and the Waco Guides. And lastly, access the AMA Strategic Practice Guides on the AMA's website for implementing specific topics associated with effective behavioral health integration, including the topic today, pharmacological treatment, as well as substance use disorder, suicide prevention, as well as broad workflow design guidance. Thank you so much again for joining us.